Oh, it is 11:30. I thought so. Okay. Dan, can you hear me? Dan's recording it. Now who's recording these? Asking me if he can hear me.
It's now. I thought it was at 11:45.
It is now.
It is.
Come on in. Okay. Yeah.
Come on in. Sign in though. You can get your
My stuff has been.
Somehow we need to keep track of who's watching this on there.
Yeah, I had them write in who's in the room with them if there's others in the room.
Deanna's coming.
Okay. Can you guys hear me? If you are watching from another site and you have other people in the office with you, please write in the chat box who's in the office with you so we know who else is attending. And Dan is recording this, I believe, so that we'll be able to get it to people who aren't able to make it. Okay. If you're just watching, though, you want to mute yourself down in the lower left-hand corner. Click on mute so that we don't hear background noise from your office. Okay? And if you write any issues you have in the chat box, then I'll be able to kind of watch that and make sure we know if anybody's having issues. Okay, Dan can hear us too. Great.
Okay. Do you think I can hear? Can you guys hear me okay?
They'll type yes in a second because they all are muted.
Can you hear
yes.
me? Okay.
Becky says yes.
Yay. Okay. All right, so just so you're aware, I've applied for CUs through the Board of Behavioral Health and Therapy, and so I anticipate them happening. And so make sure if you're following us on the Zoom, that you let Jesse know who else is in the room with you or who comes in, so everybody gets a certificate that actually attended. And we are recording this, so if you need to hop out for a few minutes and then you need to rewatch it, that's fine. Today we're going to be discussing co-occurring disorders and the counselor toolbox. This will be part of our Lunch and Learn series. Each series episode will be 1 hour, and we will be talking about really broad topics. An hour doesn't give us much time to get in depth too much, but hopefully I'll also be providing resources each week that we do a Lunch and Learn, so that if you have if you want to move further in training in that particular area, that'll give you some direction to do so as a professional. So my name is Carmen Finn. I go by Finn. I'm the current Senior Director of Treatment Services at Wayside Recovery Center. I have a master's degree in marriage and family therapy and almost 20 years experience providing services to families and individuals in behavioral health. I also teach in the alcohol and drug counseling program at Metro State. I'm on the March Ethics Committee, and I am part of the March Board of Governors for Region 11. So that is who I am today. Some of the goals we have for the hour that we're together today is that I want to be able to provide you guys some effective counseling strategies in responding to common mental health and substance use disorder symptoms that we see in a SUD and co-occurring treatment program. I want to be able to provide you guys some resources and treatment options for individuals with substance use disorders, and But hopefully you guys will leave feeling like you gained some techniques to utilize while you're counseling these individuals. So responding to symptoms, we'll just dive right in. The way I like to think about this is, what are you teaching me that you need to succeed? So the way I'm looking at symptoms is in an assessment tool of, this is what I'm seeing, and how are you teaching me things that you will need in order to succeed in an SUD treatment program. So thinking about this, we go back to kind of diving into addiction as a disease and unpacking what exactly addiction is. And so when we see symptoms, we're looking at symptomology that we'll see biological concerns, so clients who have even medical issues related to withdrawal and dependency. We'll see psychological manifestations, social and spiritual manifestations. I often have people ask me in particular, what does spiritual manifestation mean? And the way I think about it is, those individuals who your brain has not been co-opted by a substance use disorder or mental health, generally in the things that you do, you find meaning. There's some sort of attachment or meaning, higher value to what you're doing. For some people, that meaning does have to do with their spiritual approach. For others, it may not feel spiritual, but it's a meaning, a greater than outside myself. And when your brain has been co-opted by the disease of addiction, oftentimes we start to see things where you are losing meaning in the things that you're doing, and instead there's an entire focus on obtaining, using, and recovering from substances. So how that ends up all being reflected is that the individual ends up pathologically pursuing reward and relief by substance use and behaviors. And so how that pathological pursuit of drugs ends up looking is going to be different, but it also can occur while the person is in substance use disorder. In terms of drug-seeking behavior and words that sometimes you'll hear substance use providers use, and that I hope we reframe, is words like the client is being manipulative, that gets reframed in symptom. It's a symptom because of the pathological pursuit of wanting relief by some sort of substances, and then other behaviors that we see. So the first thing we like to ask when we're counseling or providing direct care to our clients is, what are you teaching me? Let me just look at your both on paper assessment, right? What does your history teach me? What does your collateral context teach me? What are you teaching me? You're the expert on yourself. How do you view, how do you frame your mental health and substance use disorders? It's important to know what are the causes of the symptoms you're seeing. And so sometimes clients will come in and you'll see that maybe there might be some sort of cognitive impairment. And so it is important for us to start to get curious of what type of assessments you may want to provide that client, so that you can rule out things like traumatic brain injury. Are they in some sort of post-acute withdrawal fog that is causing some sort of cognitive issues or concerns? So that will help us provide appropriate intervention strategies if we know what the root cause of some of the symptoms we're seeing are. And so oftentimes when we're in co-occurring setting, it gets really tricky, and it is time consuming, making sure that we're not doing an assessment 3, 4, 6 weeks down the line, but that we're quick in recognizing this client will likely strongly benefit from a neuropsych testing sooner rather than later, and that we're trying to get them hooked up with the correct assessments. And then other assessment tools that we can utilize with the client, whether that be client motivation engagement, looking at just questioning collateral contact and assessing how the client's environment perceives them. And so oftentimes even first contact with family members, asking questions to family members, when did you first notice there was a problem? what are the things you've noticed that the client has utilized in the past that's allowed them to have some success? What does success look like for your family member? Those are all a form of assessment that you can then use to kind of start to whittle down what are some of the causes and symptoms you're seeing. If you find out that, for example, your client grew up in extreme poverty, and one of the behaviors we're seeing is they're hoarding food in their bedroom, like 3 or 4 things of Mountain Dew underneath their bed, drawers filled with candy, it then makes sense for you to have an intervention of discussing psychoeducation around food insecurity, right? And that we are using that as an intervention both so that they can end up following room check criteria, but also as they move forward in their life, that having been a target behavior that you were able to work on, but you were able to work on that because you were able to do an assessment to allow you to figure out, okay, there's a reason my client has closets and their locker and everything just stuffed with food. And the other piece of this is that proper assessment can allow you to get a baseline for deciding what targeted strategies you want to use, and then whether or not the outcomes of those strategies are effective. And so when we're, for example, taking the food insecurity behavior of a client who's consistently failing room checks or consistently pulling cards for having food in their room, this target strategy and the target behavior is you want to decrease the amount of food they're keeping in your room, what interventions are you doing that'll allow you to see, is that intervention working where the client is able to then meet the goal of having a food-free room and therefore becoming compliant with our rule here. And then what are the various types of assessments that you can utilize when confronting common behavioral symptoms in SUD? I know there's some people on right now, so the question is, and hopefully you can type in and we can share with our group, what are some of the common types and various types of assessments you like to use as a clinician, usually in the first week or 2 with your client, that will help you sort of figure out what intervention strategies you want to use, what some of the causes are for some of the behaviors you might notice. Genogram. Can you talk about a little bit about what you get out of the genogram that really helps you make an assessment and allows you to then plan intervention strategies?
I think a lot of things, genograms are dealing with history, who their kind of support is, family members that we can call into treatment, traditions that they have in their life, culture.
Yep, if you heard the question on remote, if you want to just type in, we can share those answers too.
And did they hear?
Oh, could you hear Nicolette is the question. She talked about genograms being a good assessment tool, talking about family members you could bring in, supports, culture, traditions.
Other assessments?
Oh, Jake said she could not hear you.
Oh.
Okay, so if we talk in the classroom, we'll have to speak up a little bit so that they can hear us.
Other assessment tools that people have used or find helpful in their work initially with clients in order to try to tease out what are some of the causes to the behaviors that we're seeing.
I think the gains and mental health screenings like that give good and kind of background or things to pay attention to that are probably going to play into their treatment. And Sarah added the diagnostic assessment. Yep,
the DA can be incredibly helpful. And so that is one of the thoughts around making sure that it's done within 10 days. So it gives you some idea, maybe what's happening. It can be difficult to sort of, when you're doing a diagnostic assessment, for those of you who are able to do them, trying to tease out what has been related to active using, because they don't have the 90-day sober that everybody else in the world recommends you wait to do before doing a DA. But it's giving us information that we can then use to maybe build a story in terms of why the client has relapsed in the past. Have they been trying to self-medicate some sort of mental health issue?
Becky added the comprehensive assessment being a good tool as well.
Yep, so a lot of these that like Jesse mentioned, the games and like the comprehensive assessment, sometimes as clinicians we start to feel like it's just this document we have to get done, and using it with client engagement to really talk about, you can start to formulate what your initial treatment plan is going to start to look like, and really starting to engage clients in buy-in. You know, like we can work on that, we can address that, we can do that while the client is sharing their story in the comprehensive assessment, and things that they might be seeing as challenges or identifying as challenges throughout the comp assessment. So after we have multiple places of assessment done, and we will be gathering those also from collateral. So like Louise Winters, when she meets with her clients, she completes the SCOF. So that's looking at assessment for eating disorders. Of course, there's a lot of different assessment tools that you can utilize with our clients. But after you've finished the assessment component, then we really want to start to formulate an intervention strategy. My sort of technique with this is that as I'm going along, I'm starting to think, since I have 10 days to do that initial treatment plan, I'm starting to think about what it is that I'm going to be formulating in that initial treatment plan based on the assessment tools I've used and the targeted behaviors that I want to hit the ground running with. So there are some things that you're thinking of, this is a targeted behavior, and it may or may not pop up in substance use disorder treatment while the client is here. One that's common about that is clients who answer they have a history of violence, but they say that it happens when they're using. Anger management and other intervention techniques the client may benefit, or depending on what we're weekly assessing for the client, it could just be that they are a non-aggressive person if they aren't using 3 or 4 packs of methamphetamine a day. So that might be something that is kind of in the back of my mind, that I'm a wait and hold on an intervention strategy for that particular thing. And that might be something that I seek consultation around, that I'm only here 40 hours a week. If you guys start to see things that appear aggressive, extreme forms of irritation, I want to be talking about anger management sooner rather than later about this client, and even thinking about referring outside as an intervention strategy and talking to the client and getting them buy-in about why that might be helpful to focus on some anger management strategies while they're here. So seeking consultation ahead of time. Sometimes we go into, like, for example, multidisciplinary staff meeting, and we're like, I don't know this client a whole lot yet. And for myself, one of the strategies I like to do is try to get as much of that collateral stuff done with their family members, and brief connection with the client, and reviewing the comprehensive assessment, so that I'm coming to staff meeting and I'm able to say, this is what I'm thinking, you guys, that I'm going to be wanting to work on rather soon with this client in terms of intervention. And then in collaboration with the client, offering client choices. These are some of the things that we could focus on right now, that just looking at what you're bringing to the table, you may seem more motivated to do that. So let's start with the things you're motivated with, highly motivated with, so that you can feel success. Sometimes we want to tackle that thing that the client is like about, but we see it as a big priority. But if the client doesn't feel success rather soon in treatment, that's where we start to feel like they're more likely to have AWOLs and ASAs. So what are some things that you know that you could do with a client that they could very quickly start to feel success, even if it's turning in that first homework assignment, even if it's having that first family session. So offering clients choices, and then collaborating with their client, family, and collateral, and that is all very clearly defined and communicated, including when are we implementing and starting some of these intervention strategies, and how will we know that they're being that they're having success. So then after you've implemented some of the intervention strategies, which I assume will be in your initial treatment plan, you'll want to, of course, document. That might include behavioral agreements depending on right away, as opposed to depending on the type of behavior the client is reporting and the family is reporting happens. And so not all clients respond well to behavioral agreements, and if they're saying, no, I really want to work on this, this tends to be something that happens, especially when I'm in residential treatment, there's no reason why you can't be proactive with the behavioral agreement as opposed to being reactive after things already sort of flare up. So that's a possibility. These are just suggestions. Holding collateral meetings up the river more instead of being reactive, where it's like, okay, all things are falling apart, and so let's bring the PO in. The PO can say like if-then conversation with the client. Having collateral meetings on the front end while things are going relatively well, the client's experiencing some success, they're highly motivated, and so their experience with collateral meetings aren't just around when things are kind of hitting the fan. So the other piece of that is when the collaterals come in, they can reflect how they think the client is doing. And family members are wonderful with this in collaterals, because often they'll come in and say, you look so good, you look so happy. And again, this is about the client receiving that feedback that is reinforcing they're having made the decision to come here. Or even if they were court ordered to come here, that it's then providing them that, oh yeah, I'm getting something from this. It's not only impacting me, but look at how happy it's making my family members. And so they're getting that reinforcement for maintaining the trajectory they're on, as opposed to waiting to do collateral meetings until the behaviors are sort of explosive, that we have concerns, and all those type of collateral meetings can be incredibly helpful if you've already had the one that is done just for monitoring purposes up towards the front end of the stream for treatment. Then if you do have to have this one, there's already been a precedent of those meetings going well, and that you were able to build a good communication style in that system with the client, in common language and common understanding and common goals, so that this meeting over here will actually go better. And then, of course, utilizing your individual sessions to actually assess and monitor what's happening. And so the treatment plan review can often feel like it's just something I have to get done. And there is a way to engage in conversation that it feels incredibly therapeutic, where the client is able to self-reflect how each method is actually helpful for them. And by naming that, they're naming their successes. And so they're actually, again, reinforcing like, when I've done this, this is what's been really helpful for me. Or them saying, I actually haven't made that phone call that I said I would. Okay, what's the barrier? Let's just do it now. Do you feel that success? And then let's put something else now. So you got the appointment, now what's the new goal? So that you don't linger week after week with the same goals that aren't moving. And so you help the client sort of push through the goals that are stagnant and partner with them to do that. And so they're consistently feeling success as they move forward. Success for them, right? And whatever that they're working on. So that's what I mean when I say it's important to stop or adapt interventions that do not appear. So I would say you partnering with them to make that phone call would be an adaptation of what the initial goal was, which was the client was going to leave your office and make their own phone call. I would also say that maybe they open up and say, I've been thinking about it and I don't think I'm ready to start EMDR right now, or I'm very hesitant, or I'm very scared. It's like, okay, do you think you can try something else then? Like maybe a traditional just talk therapist. You're going to go in, they're not going to do a strict specific technique. And so I'm just curious what you guys think. How do you know when an intervention is effective?
When the clients like are feeling positive about what they're doing, it is about them, and it's kind of like, hey, like I've been doing this or been working with this person on this, and I feel different. And you can see insight too, over time that they start to think differently and look at the world in a different way and kind of react with the world in a different way. And I mean, that's just something visually you can kind of see and other people notice. And I think getting feedback from family and people in their lives is really important and valuable, like you said, because a lot of times if you're talking to family or had those collateral meetings, like people that have known this person, that stuff really matters. Like, wow, you're really different than you were a year ago in a lot of, amazing ways. So I guess that's how I use it.
Wow, you're approachable now, and I can talk to you, and
yeah.
Yeah, I like that aspect of you can actually see a switch. The client feels good about what they're doing, and the other piece of that, in terms of the counselor, is oftentimes we'll start to feel like, oh my God, all I do is work on problems. Like somebody will say, you need to do this for the client because they're showing up this way in the community. And when we start reframing it where the client is empowered to take ownership of their interventions, which means they get to own their success. When we do have to have those conversations, we get to say, look at what you did over here. How do we use your movement over here and say you can do the same thing with this particular issue or this particular behavior? So I saw you radically change here. How can I help you provide that same thing that you did here? Because this particular thing seems to be causing a lot of problems, whether it's with your peers or the staff or your ongoing recovery. Like, you did this. Now you have this problem with your late for passes all the time. Can you use some of those same techniques you did to be so successful here? And having that language with the clients as opposed to that punitive, like, I need you to fix this. I'm not going to let you go on passes anymore unless you do. It becomes partnership, it's collaboration, and then the client feels like, yeah, I did this here, and I do want to do this here, or I do want to fix it. And if the client says, I have no motivation to fix this, I'll just pull the good habit cards. I don't care. That's a whole nother behavior that they just taught you. Now they need something different, right? So now we're noticing they don't seem to be bought into the strategic structure we have here. And maybe they don't realize that the structure we have here is also based on neuroscience and retraining those brain pathways and all about brain plasticity. And so you go ahead and tell them all that until their eyes just glaze over and they don't know what they were just hit with, right? And so maybe one of your intervention strategies for the first time is providing them the understanding of why we have some of the rules we have that actually is shown to be effective with clients in early recovery to help, for lack of a better phrase, sort of retrain their brain in some of these habits.
We have some input from others. How do we know when a client or an intervention is effective? When a client appears to be working on changing the behavior, is what Becky said.
Yes. Yeah, so that was why the assessment and cause piece is so important, because you have to know the specific behavior you're trying to change. And so then you can call it a target behavior with client. And so whether that be, it seems like they're stealing in the house, or they're late for passes, or they're having a hard time with emotion regulation, that you've got to really get specific and detailed of what exactly it is that you're looking to decrease in behavior, or if there's all these positive things, how do we increase? Like, you're such a leader over here, and then when you get angry, it's like you lose all that. And so how do we help bring the strength you have 3/4 of the day into this other quarter part of your life? So instead of focusing on the negative, like stop doing that, we could say start doing this here, because you've got the strength. So common symptoms, and these are symptoms of other things that we see in treatment, and these could be symptoms of mental health, right? So when we have angry and impulsive outbursts, that can be due to post-traumatic stress disorder, major depressive disorder, traumatic brain injury, or some other developmental delay from birth. It could be, I mean, I could go on and on, right, of all the things that can cause angry and impulsive outbursts. It could also just be, I came from a very loud family, and this is how I talk when I'm frustrated. And that would be totally fine in my family, and I have a hard time knowing that other people come from different cultures that are quieter and more passive in how they communicate. So a symptom, though, in treatment often can be angry and impulsive outbursts, late from passes, not accountable to passes, sleeping in and missing meetings and groups, so or just non-attending participation in programming, a reoccurrence of use, interpersonal difficulties with peers, stealing, low motivation, not completing assignments, and disruptive in groups. Would you guys say that's a good bulk of the various things that you're trying to target in terms of behaviors with immediate symptoms you're seeing in substance use treatment? And what are some other symptoms that you guys feel like you're consistently working on with clients in more of an acute way?
Memory issues?
Yeah, so time management and memory issues and organization.
Jake says, affirmations of their strengths, successes, progress, even when addressing problem behaviors. I think that might have been related to the last question.
True that, Jake. So what are some other symptoms that you'll see in treatment that you end up feeling like need to be addressed more quickly or more acutely in order to help them make it through a setting like this?
Staff splitting or inflation.
Yeah.
I think honesty, like being comfortable with being vulnerable and honest.
So so the symptom is dishonesty, and one of what you're working on is trying to have them feel comfortable being honest, or maybe even, they might not even recognize they're being dishonest because denial is a symptom of addiction. And so how do we even get them to have awareness that some of the things they're saying is actually not true or isn't based in shared truth among individuals? So this is going to be hard for the people that are on here. I did not expect so many people to be so excited about the Zoom, but hopefully you're watching with somebody else. But I'm going to ask this group in this room to get into small groups. And I think you'll have to do this alone if you're by yourself on Zoom. But get into small groups of 2 to 3 and hypothesize for those symptoms what could be possible causes, because that would change what type of intervention strategy. So for example, one of the things I've noticed and why I want to do this today is when people have angry and impulsive outbursts, people tend to get the same technique for them here. Like, let's get a de-escalation plan going, and let's do a behavior agreement, and let's tell them they can't do that anymore. And so, but depending on the cause of their angry and impulsive outbursts, it would actually change what type of intervention strategies you want to try with that client. And so hypothesize for each symptom what could be possible causes, which would then lead to different assessments. So then what assessment tools would you utilize to determine if that hypothesis was you were on the right track? And then based on assuming that you were correct on that, what intervention strategies would you try? So go ahead, get into your small groups. Let's spend about 10 minutes.
I'm going to move this closer to see, because I don't think they can see the slides on there. But in the meantime, you might need to repeat the questions that they should type an answer to.
Okay, yeah, hopefully they'll be able to see these questions down here.
Reach there.
Okay, so my hypothesis
Is your battery dead?
No, but my computer shuts down sometimes on its own. It just, stops.
You just got that from
I know, it's been an issue. Let's see, is this too close? There, it's gonna be tight to you. Plug, if not, we can. Perfect. out. So those of you on the phone, I don't know if you can see the slide or if it's backwards. To me, it looks like it's backwards up there. But if you need clarification on what to be discussing and typing in, you can type in here. Yeah, Jake says it's not legible to them. So you might have to reiterate. So the answers or the questions they're answering are talking about some of the symptoms that we see in treatment. What could be possible causes? What assessment tools would you utilize to determine the cause? And what intervention strategies would you try for some of the common symptoms? Yeah, they can see it, but they can't read it. Talking about some of the symptoms you see in treatment, how you can assess the causes and what kinds of interventions you can use. And if you have specific questions, you can type them in and Finn can answer them here.
So they can't read?
They can't read it because it's so narrow, I think, but we'll send out the PowerPoint with the recording.
Yes, good idea.
So people see the questions, but just for them to be able to discuss, you might need to stay right now.
Right. Well, this is good learning, right? Because we're gonna.
We can show a PowerPoint through this. Like we could have, if you were the one logged in, you could share your slides, or if you sent them to me, I could share your slides, and then they would see them and not you, your slides.
Oh, I like that.
Yeah. So maybe we'll try that next time.
Okay.
For now, oh, Jake says yes. I don't know what she's responding to. That's a good idea, isn't it? We'll send out the PowerPoints for those of you on the phone after this. I know that you can't see the slides very well, but if you have questions about what we're discussing, ask Finn here. She can see your chats.
And we're gonna do this for the co-occurring 4-hour trainings
I
too.
think we can.
Yeah, and then you put them on the intranet. What kind of soup do you have?
The vegetable soup. Just bring a spoon, so I'm just drinking it. It's good. There are a few chunks that surprise me sometimes. I gotta keep my eyes on here. Nobody's typed anything in yet. So we have on the phone for now. I think Shantae was going to try to log into from Wellness, but she's not on yet. Cool. How many more slides do you have? I'm just joking.
I went a little overboard. I got excited.
Oh, that's funny. Is there anything they could type in an answer to this that would be helpful to share in the group?
Any answers for this?
Yeah. What would be helpful for them to type in?
We could probably type in what the small group comes up with. Or they'll be able to hear them chat.
Mm-hmm. If you're listening on the phone and you want to type in a little bit about what your group is discussing about the symptoms, the possible causes for symptoms, how you assess, and what interventions you might try, you can type in, and then we'll bring the group that's in the room back together to discuss here in a little bit. I think you'll need to summarize what they say so that they can hear on this. Okay. And I'll watch the chat.
Okay, so you guys are up. So what are some of these symptoms? So based on these symptoms, what are some of the possible causes?
So for angry, anger and impulsive outbursts, I kind of just suggested that I see sometimes individuals who didn't have like a secure attachment with their primary caregiver, like a lot of times just, kind of like, I'm gonna hurt you and push you away before you reject me or push me away. I noticed that's the I worked with.
So then intervention strategy for something that you might be noticing is based on some attachment issues. What would be some of those strategies that you might want to use for intervention?
I mean, I think like just kind of evaluating how that's played out in their relationships in the past can be helpful. Like, have you had difficult relationships in the past? You want to improve them? Has this reaction like helped improve them and help you develop support circle or healthy relationships or stable relationships? And I mean too, I think just for me as a counselor, being able to kind of be with them in those moments when they're angry and kind of trying to push you away and kind of providing them with that kind of unconditional acceptance. To me, it's very difficult. That approach them for everybody.
Yeah.
And I feel like that can be really helpful because that kind of is a reparative experience for them where they're like, oh, okay, like that doesn't always happen.
Right.
Like when I behave in a certain way, I'm not always going to be pushed away. So I think that's
Can you summarize?
Oh, yeah. So some intervention strategies when you have clients with attachment issues might be some, reparative healing in terms of modeling a relationship where if they are attempting to push you away or attempting to disconnect, that you stay involved in the relationship. However, I would add, and you didn't say this, is just making sure that you're still able to set boundaries. So it's okay to set boundaries and say, I hear you're really angry with me, and I'm going to check in with you later after you've had a few minutes to calm down because the things you're saying to me are really hurtful. And, I need my own space to deal with that hurt. So let's take a few minutes to break from each other and we'll come back. And saying that in a non-judgmental but firm way that shows care. What about not attending programming? That's a common one. What are some hypotheses people have for what cause people have for not attending programming? Depression. Common one.
Maybe fear about not understanding it and not being able to comprehend, and so they just avoid.
Yeah, avoidance of having to talk about hard things, avoidance of your own emotions bubbling up because you don't know how to manage your emotions. Fear of comprehension. I don't want to. People with social anxiety, fear of the 15 other people or sometimes 40 other people in the room, not wanting to be put on the spot. So what are some intervention strategies you could utilize with depression, avoidance techniques, for those who are coming from a place of fear?
For depression, trying to assist them in establishing mental health services like therapy or medication if they're open to that.
I think too, setting goals, like looking and saying, okay, you're required to go to 30 hours of programming. Last week you had 22. How can we show a trajectory of improvement? How do we get you to 26 this week? And let's set a goal for that. I think when you have depression, everything can seem incredibly overwhelming. So trying to break it down, or even just on a daily basis. Monday last week you missed one day or one group, or maybe the whole morning of a group. How could I get you to at least that second group in the morning on this Monday? So speaking of clients who are not attending, when is your client teaching you that they need something else? Meaning not the level of co-occurring treatment that we have. So thinking about when does your client need a higher or lower level of care? How do you coordinate that early on and facilitate this? When do you let the client aware that you have concerns that they might be needing a higher or lower level of treatment? And so this can come up and come up often, particularly with non-attendance to treatment, because if you're doing your best to assess what's happening and you're trying intervention strategies and you're on your second or third week of the client grossly being under the amount of services they need, at some point the client is saying, I am not able to get my mental health stabilized enough, as fast enough to be able to participate in this level of treatment. And so that client might need crisis mental health services to stabilize, get on the appropriate medication, show that they can participate and sit in a chair and get up in the morning to be able to attend this level of treatment. And so how do you talk to the client about this is now going on the second or third week? The intervention strategies we're trying are not effective. You're indicating this is your depression. I don't have a reason to believe it's something else. And so you're teaching me that the mental health services we have to try to stabilize you aren't fast enough, and we can't just continue week after week like this. So let's do something very intensive for your mental health, get you transition to more crisis stabilization for your mental health, because you are showing non-participation in treatment, which means that you're not engaging in basic life skills, right? Getting up in the morning, brushing your teeth, dressing yourself. And so how do you begin talking to clients about that, and when do you start talking to your clients about that? And are you aware that we can go send a client to get stabilized for the mental health, hold their bed for up to 10 days, and bring them back?
I think being really transparent and like going to programming is part of the treatment plan. And so it's just refocusing on what are your goals? These are your goals. What's getting in the way? So just being really transparent. And I think as soon as we're seeing things, it could be just a simple check-in of like, hey, we're in the group today. What's going on? Oh, just today I had an off day. I couldn't do it. Okay. Then if there becomes a pattern, just we're continually checking in.
Mm-hmm.
Summarize.
Yeah, okay. So Nicolette just said that you want to be upfront with the client and talk to them as soon as you're aware of something. And that way, if they didn't come to programming, as soon as possible, you're checking in with them and asking them why they didn't attend programming. And if they're saying, oh, I just had an off day, that you're continuing assessing and making sure that it was just one day as opposed to a pattern. And that you're letting clients know and they're aware of what the possible next recommendations would be if patterns continue without improvement after we've done intervention strategies. And also reminding clients that these are their goals that they set and how not attending programming is inhibiting their ability to meet those goals. So I mean, some of the things to consider is asking yourself, is the client responding to intervention strategies? One of the things I see, I'm in both staff meetings, is it does not always seem clear to the clinician what the actual intervention strategies have been. And so saying something like, well, we've talked about it in an individual session, isn't necessarily an intervention strategy. Certainly you can say that you talked about it to develop intervention strategies, but that in and of itself isn't an intervention strategy. And so really documenting, like, we talked about doing these things in session, and these are the things, and then documenting that in, so client agreed to begin using an alarm clock, just basic strategies like that. And then after you engage the intervention strategies, has there been evidence of improvement? If you've exhausted intervention strategies and your client is like, I don't know what else I can do, and the pattern has continued into week 3, we're now getting into almost 21 days of treatment where they're not showing improvement. And that for some places, that's almost like an entire treatment episode, 21 days, right? Thank goodness we're not a 21-day program. But because we're now in the 3rd week, you know, somewhere between that second and third week, you're having that conversation of saying something, we might need something more here because we don't have some of those levels of intensity for mental health that other places have that we're able to offer you on site. Like we do not have on-site psychiatry. The other thing to consider is the symptoms so extreme that they're interfering with the abilities to others to receive safe and effective treatment, and the client is non-responsive to intervention. So the other thing I see this a lot is with angry outbursts. So are the outbursts such that they're interfering with the abilities of others to receive safe and effective treatment? Yelling in and of itself doesn't mean unsafe, right? So that's something we want to dispel. So when I'm talking about outbursts, I'm talking about things like veiled threats, posturing, abusive language that's happening when they're having these outbursts. And so does those types of things happen, and that's interfering with other people's ability to receive effective treatment. The key here is though that we need to, as long as it's not an immediate safety issue, we do need to try to provide intervention strategies for that above and beyond the cookie cutter, let's just put them on a de-escalation plan. We need to know what the cause of these outbursts are from, and then do intervention strategies that are specific to what we've assessed as the cause of some of these things. And if you yourself feel like this is an area where I need further training in, there are trainings in terms of how to address behaviorally anger with your clients.
2 minutes.
Yep. So some common intervention strategies: collateral family members, referral to additional outside support, modify, lessen, or restrict passes, for getting client input on their own intervention strategies, increase the number of groups they're attending so they can stay a medium and you can still ask them to go and attend a specific group above and beyond their 15, right? Providing them homework. For some clients, that quiet time, especially if they're like an INFP, where they can sit and think through and process, can be extremely helpful. Peer-to-peer engagement strategies via issues group or community meeting, asking clients to bring up some of the things that are occurring for them in issues group. Acute settings, COPE, crisis stabilization, using DBT, diary cards, life skill building, so skills building and coaching. And there's obviously a lot more other common interventions. Make sure you document the interventions you're doing. Usually those will happen on the treatment plan, but they need to be somewhere. The progress and the effectiveness. Involve others. Make sure you're consulting and involving family members and collaterals. Be willing to adapt, continuously monitor and assess. Remember, the client is the expert on themselves. Women change through and towards a relationship, and so that's why I keep emphasizing involving others, involving their peers, involving family, involving collaterals. Remember to involve the client as soon as you are aware of treatment goals and strategies. That's trauma informed. We want to keep them involved in everything that's being decided about them. And remember that honesty is an ethical principle. There's a thing, and some of you guys who are like podcast people, there's this thing called the Actual Counselor Toolbox, and it's a podcast. There's one weekly on pretty much every topic you would ever want. And so here's one on ethics and self-care, and so it's a link in here. So one of the things is clients who have improved after 1 year continue to improve after 5 statistically. So everything we're doing is the groundwork to having them get to that year, right? In this level of treatment. Let's see, here's one, the podcast Counselor Toolbox on Cultural Competency. Fast Tracker is an important referral to utilize if you're looking for more mental health resources for clients, as well as substance use disorder. For those of you who haven't used it, getting on there and playing around with it can be incredibly helpful. So that concludes our first Lunch and Learn on co-occurring disorders and the Counselor Toolbox.
And we'll send out the PowerPoints to everybody so that you can get those links and everything, right?
And your certificate of attendance. So, questions?
Thank you, Finn. And if you're listening on, please, and if anybody joined you in your office, let me know who that was so we know that they're there. They're saying thank you.
Okay,
Good
thank
job,
you.
Finn.
Bye, guys.
Jake said thank you. That was good. And Becky said thank you. All right. Let me know if anybody else joined you during the broadcast. And then Dan, you can stop the recording and figure out how to get it to me. Thank you. Okay. The recording's still going. I don't know if Dan's there.
Was Amber leaving?
Yeah.
How long did you call her sister?